At a dim evening gathering, a 79-year-old grandfather misses the speaker's words and cannot clearly see the facial movements that might fill the gaps. He stops asking for repetition, receives less of the conversation, and appears withdrawn, even though the immediate barrier is accessed through two weakened channels. The first answers that two weakened senses can create more than two inconveniences, because each sense normally helps fill gaps left by the other. Hearing supplies speech timing and sound detail. Vision supplies facial movement, gesture, spatial context, object contrast, and cues about who is speaking. This does not mean every combined difficulty exceeds the sum of its parts. It means compensation becomes less available when both input channels weaken. In this constructed case, his hearing is reduced, his low-contrast vision is weak, and the evening room makes faces harder to distinguish. When a word disappears, facial motion cannot reliably reconstruct it. When a face is unclear, sound alone cannot always identify the speaker or message. The brain must then infer more from less input, while tracking the topic, speaker, and social timing. That raises functional demand before memory is judged. So the first correction is behavioral. Apparent disengagement can begin with missing information, but that observation alone cannot reveal sensory, cognitive, or social cause. Compensation is easiest to see in conversation. Clear facial movement can support uncertain speech, while audible speech can identify information in a low-contrast scene. Each channel supplies evidence the other can sometimes verify. The same overlap supports navigation. Vision locates obstacles and landmarks. Sound can signal approaching people, traffic, doors, or activity outside the visual field. This redundancy becomes most useful when one cue arrives late or incompletely. When both channels weaken, communication and navigation may demand slower pacing, closer distance, brighter contrast, quieter surroundings, or explicit confirmation from another person. Cognitive testing can carry the same access problem. Spoken instructions depend on hearing, and visually presented shapes, symbols, or layouts depend on vision. An incorrect response can enter the score before reasoning begins. The mechanism payoff is an access audit before interpreting performance. Identify what the task required the person to hear and see. Then verify both. The Rancho Bernardo study of healthy aging followed older adults with measured visual and hearing acuity and repeated cognitive testing over time. The repeated design distinguishes baseline differences from changes observed during follow-up. Combined low visual and hearing acuity was associated with poorer baseline performance and faster decline on several cognitive tests during follow-up. The affected measures did not represent every dimension of cognition. The association was adjusted for measured factors, which improves comparison. Adjustment still cannot remove every difference or create random assignment. Residual confounding remains possible even after careful statistical control. The cohort's demographics and sensory thresholds limit universal generalization. The result describes this studied population under these definitions. Not every older adult. Threshold definitions also determine who enters each sensory group. The first evidence payoff is longitudinal association. Combined impairment accompanied poorer cognitive trajectories. The design did not prove that sensory loss caused the decline. One explanation is measurement. A test that uses quiet speech or small visual material can partly record sensory access instead of the intended cognitive ability. Accommodation can change measured performance within the same session. A second explanation is participation. Combined difficulty may reduce conversation, reading, travel, hobbies, or social activity, changing daily cognitive demands and test context. Reduced participation is a plausible pathway, not a proven mediator here. A third explanation is shared health. Vascular, neurological, or other processes may influence hearing, vision, and cognition together without one sensory change causing the others. That shared cause root preserves correlation without sensory causation. Reverse influence is possible too. Cognitive change can affect test following, symptom reporting, device use, appointments, or continued participation in demanding activities. Direction may run towards sensory management, as well as from sensory change. These routes predict different patterns. Access-sensitive errors should change with accommodation, while broader difficulties may persist across well-heard and clearly seen tasks. The contrast improves interpretation without settling diagnosis. A second study examined population data from about 5.4 million older adults, comparing reported hearing impairment, vision impairment, dual impairment, and serious cognitive impairment. Scale improves precision, but does not change the design's temporal structure. The study was cross-sectional. Sensory and cognitive status were observed in the same broad period. It did not follow individual change across time. Prevalence and association can be estimated, but sequence remains unknown. Combined hearing and vision impairment showed a stronger association with serious cognitive impairment than either reported impairment alone. That pattern remains group-level association. It does not describe a fixed personal multiplier. Self-report, proxy report, residual confounding, and the cross-sectional design limit interpretation. Reported status is not identical to standardized measurement. Confounding can remain after measured differences are adjusted. The second evidence payoff is scale with limits. A very large sample strengthens the observed association, but size cannot repair cross-sectional timing or measurement constraints. Precision and causal identification are different strengths. Stronger association does not mean a universally multiplicative effect. Group averages can hide wide variation in sensory severity, support, health, and daily environment. Support can change function even when measurements look similar. Nor can an association become an individual risk estimate. A person's age, measurements, health, supports, testing conditions, and trajectory require direct evaluation. Objective and reported impairment definitions can identify different groups. Threshold choices also change who is classified as hearing, vision, or dual impaired. Cognitive instruments differ too. Some rely heavily on spoken instructions, visual scanning, or both, so accommodation quality can alter observed performance. The practical rule is to record definitions and access. What was measured, how impairment was classified, and whether every instruction and item was available. For assessment, begin with real situations. Does difficulty appear in quiet one-to-one speech, group conversation, low light, unfamiliar travel, reading, or mixed tasks? Then vary one support at a time: lighting, speaker distance, background noise, contrast, pacing, face visibility, or confirmation. Observe which changes improve access. Separate access-sensitive errors from problems that persist after both channels are supported. Improvement clarifies the barrier, but does not certify normal cognition. Persistence also needs interpretation. Difficulty that remains in accessible formats can be meaningful, yet a qualified clinician must integrate health, history, and examination. The assessment payoff is coordinated interpretation. Improve access first, retest the relevant function, and preserve uncertainty about diagnosis and cause. Now, the boundary functional burden is real even when dementia causation is unproven. Better communication matters independently of any cognitive prevention claim. Hearing or vision care can target communication, safety, independence, and sensory function. Those are valuable endpoints even if dementia outcomes remain unanswered. A rational exception is successful compensation. Some people with measured dual impairment function well because environments, devices, strategies, and partners supply robust support. That case refines the claim. Measured impairment does not determine identical disability, participation, or cognitive performance across people and settings. The converse matters too. Cognitive difficulty can persist when hearing and vision are adequately supported, so sensory accommodation cannot rule impairment in or out. Neither study proves that treating hearing, vision, or both prevents cognitive decline. Observational exposure, outcome associations cannot provide intervention effect. The large study explicitly called for causal and intervention research. That request marks an unanswered question. not a hidden conclusion. The corrected conclusion is layered. Combined loss can remove compensatory options and accompany poorer cognitive outcomes, while cause and treatment effects remain unresolved. Return to the grandfather. Moving closer in better light with one facing speaker may restore enough information for him to rejoin the discussion. That improvement shows access was contributing. It does not establish that sensory access explained every earlier mistake or every future difficulty. If difficulty persists across accessible conditions, the concern remains meaningful. The next step is broader professional assessment, not a home diagnosis. Coordinated care prevents one sensory result from explaining everything. Audiology, eye care, primary care, and cognitive assessment can answer different questions. The full answer is that losing both channels reduces backup information and is associated with poorer performance and faster decline on some cognitive measures. But access, participation, test design, shared health reverse influence, and cognition interact. The observed association cannot select one pathway for an individual. Address sensory function for communication, safety, participation, and quality of life. Judge dementia prevention claims only through suitable intervention evidence. For prevention claims, ask which treatment, which population, which cognitive endpoint, which comparison group, and how long participants were followed. The resolved framework is support, retest, coordinate, improve both channels where possible, reassess performance, and integrate sensory, health, and cognitive evidence. For an appointment, describe concrete situations, lighting, background noise, speaker distance, missed words, unreadable objects, withdrawal, navigation errors, and recent changes. Bring the sensory devices normally used, and report when instructions or objects are unclear instead of guessing. Access is part of valid interpretation. New or worsening combined sensory difficulty deserves qualified assessment. Coordinated evaluation can improve function while keeping cognitive interpretation evidence bounded. Two weakened channels can remove the backup signal, restore access, then interpret performance. Optimize the protocol, protect your brain, and I'll see you in the next dataset.